السلام عليكم ورحمة الله وبركاته. أهلا وسهلا بحضراتكم في Case of the Week 6. This is a case referred to my center for the third trimester obstetric ultrasound. The study revealed all around extraaxial collection. The collection was hyperechoic with right cerebellar hyperechogenic focus. The hyperechogenic cerebellar focus shows no detectable vascularity on color Doppler and power Doppler. The middle cerebral artery velocimetry was high, and the resistivity of middle cerebral artery was also high. Also, there is a hyperechoic focus noted at foramen of Monroe, and also the right cerebellar lesion is well seen here, with leveling the extraaxial collection seen at the right cerebral convexity. Here also the extraaxial collection at right frontoparietal region. Also there is hyperechogenic focus at fourth ventricle, and there is mild asymmetry at basal ganglia bilaterally, suggesting possible right codolentiform hemorrhage. So the findings are: widened the extraaxial space by subdural complex leveling fluid sediment hemorrhage. This hematocrit level can be seen in acute on top of chronic hemorrhage, as well as clotting disorders and on anticoagulants, with thickened sulci suggestive of coincident subarachnoid hemorrhage, hyperechoic hemorrhage at foramen of Monroe, hyperechogenic hemorrhage at fourth ventricle, right cerebellar hemisphere hemorrhage, asymmetrical basal ganglia echogenicity with possible right codolentiform hemorrhage, increased RI of middle cerebral artery, possibly sequel to increased intracranial tension, with increased velocimetry, peak systolic velocity equals to 88 cm per second, suggestive of possible fetal anemia with marked severity. The incidence of perinatal stroke, defined as that which occurs between 28 weeks of gestation and 28 days of postnatal life, is reported to be 1 in 4,000 life and about 1 in 10,000 pregnancies. Types: subdural, subarachnoid, intraparenchymal, subependymal, and intraventricular. The most frequent form in the fetus is the subependymal and intraventricular hemorrhage. It is also frequent in the premature neonate. In fact, in premature infants less than 32 weeks and below 1,500,000 grams weight, its incidence reaches 30 to 40%. Pathophysiology. Observation of early cardiovascular hemodynamics suggests that the pathophysiology of intraventricular hemorrhage in human preterm infants may relate to a hypoperfusion-reperfusion cycle. About 80% of upper body blood flow goes to the brain, so when superior vena cava flow is very low, it is likely that the cerebral blood flow is also low. Data on humans have pointed to early low cerebral blood flow being a risk factor for intraventricular hemorrhage, and the germinal matrix is uniquely vulnerable to ischemic injury because of the watershed nature of the blood supply. An antecedent ischemic insult to the germinal matrix capillaries, which are the highly vascularized region with thin-walled vessels, possibly occurring antenatally, was probably important in the pathogenesis of intraventricular hemorrhage. In a premature baby with an immature autoregulatory system for vascular tone and consequently for cerebral blood flow, hypoxia and hypercapnia can cause an increase in blood flow, thereby distending the fragile vascular bed of the matrix. The etiology: this can be of placental, maternal, or fetal origin, or idiopathic. Maternal causes: history of recent abdominal trauma, anticoagulant therapy such as warfarin, coagulation disorders and hyperpyrexia more than 38 degrees, and viral or bacterial infection, as well as medications such as cholestyramine and drugs such as cocaine and scissors. Fetal predisposing conditions include congenital coagulation factor deficiency, mainly factor V and X, cerebral arteriovenous malformation, congenital tumor, severe twin transfusion syndrome. The most important determinant of fetal intracranial hemorrhage is represented by an autoimmune disease, namely feto-maternal alloimmune thrombocytopenia. Feto-maternal alloimmune thrombocytopenia is due to the maternal production of antibodies against paternal antigens present on fetal platelets that are not recognized by the maternal immune system. Maternal exposure to these antigens during pregnancy can lead to production of various classes of immunoglobulins. The immunoglobulin G antibodies are small enough to cross the placental barrier and enter the fetal circulation, causing severe thrombocytopenia. Unlike hemolytic disease of the newborn, female can also occur in the first pregnancy if there is parental incompatibility. Depending on the time of onset, the disease is referred to as fetomaternal alloimmune thrombocytopenia or neonatal alloimmune thrombocytopenia. Fetomaternal alloimmune thrombocytopenia often leads to severe hemorrhage and even intrauterine death during the second or early third trimester. Neonatal alloimmune thrombocytopenia is the most common cause of severe thrombocytopenia in neonates. Among the various platelet antigens involved in females, the immunization against human platelet antigen is by far the most common, accounting for 80 to 85% of cases. The importance of recognizing this cause of fetal cerebral hemorrhage lies in the fact that it can be effectively treated if the disorder if disclosed prior to the hemorrhagic episode with the intravenous immunoglobulins and the intrauterine transfusion of compatible platelets. In some cases, the cause of the hemorrhage remains unknown. Ultrasound diagnosis. The ultrasound appearance varies with the size, location, and age of the hemorrhage. Grade 1 hemorrhage at the caudosalamic groove is rarely detectable. It can sometimes form a subependymal cyst, which represent an occasional finding. Grade 2 intraventricular hemorrhage without ventriculomegaly, and grade 3 intraventricular hemorrhage with dilated ventricles. Presence of hyperechoic clots which may fill the entire ventricle or be scattered within. It can be limited to one ventricle but is often bilateral. The third ventricle may also be involved. The ependymal wall appears hyperechoic and irregular due to chemical ventriculitis caused by the blood. The presence of ventriculomegaly can persist even after the disappearance of the clots due to the obstruction of the ventricular outlets by the clot debris. And grade 4 is the most severe form, characterized by clot in the parenchyma, which appears as a hyperechoic, usually oval area. This often evolves with time into a porencephalic cyst. Here is a graph representing various types of cysts lying in close to the anterior horns of lateral cerebral ventricles. When it is at the superior lateral margin, it is usually the benign form of conatal cyst, and when it is superior, usually it is periventricular leukomalacia. And when it is posterior to the foramen of Monroe and inferior to the anterior horn angle, superior lateral angle, this is usually a subependymal cyst, which is equal to germinal matrix hemorrhage. Here is various types of hemorrhage by cases from the web. Here is intraventricular hemorrhage that migrated into the parenchyma with hemorrhage in the third ventricle. Here is leveling debris noted at the ventricles, which were misdiagnosed at early exam as cortical dystrophy. Again, this is a case of grade 1 injury at the germinal matrix, grade 2 at the ventricular system without dilatation, and evolving into grade 3 with dilatation of the ventricles. And here is an extension into the parenchyma with the subsequent development of porencephalic cyst. Here is also a porencephalic cyst with here hemorrhage extended from the third ventricle into the parenchyma, evolving into grade 4 hemorrhage. And here is a hemorrhagic focus in the cerebellum that was followed up later in pregnancy and at postnatal period with complete evolution and almost agenesis of the involved cerebellar hemisphere at postnatal MRI. Differential diagnosis. The most important condition that needs to be distinguished from hemorrhage is represented by cerebral lesion associated with infection, because in some cases, such as cytomegalovirus, the infection itself may be responsible for intracranial hemorrhagic events. The differential diagnosis should rely on an accurate maternal obstetric history and on the results of blood tests, which will show recent seroconversion. The other differential diagnosis is bleeding cerebral tumors. The main tumor is vascularized on color Doppler, and MRI is helpful in diagnosing such cases. And gray matter heterotopia and cortical dysplasia is a third differential diagnosis. Obstetric management. Try to determine the cause of hemorrhage. MRI should be considered as a complementary study for further evaluation and the characterization of the brain in the setting of non-specific or inconclusive sonographic findings. Maternal testing for coagulation disorder. Platelet antibodies to be done in order to detect possible fetal-maternal alloimmune thrombocytopenia or congenital coagulation disorders. In the case of fetal-maternal alloimmune thrombocytopenia, fetal platelets or whole blood transfusion may be needed together Intravenous immunoglobulin with or without steroid may also be needed. In the United States of America, fetuses with intracranial hemorrhage are delivered by cesarean section in order to avoid additional bleeding as a result of head compression during labor and vaginal delivery. The possibility of recurrence in future pregnancies in conditions such as alloimmune thrombocytopenia to be considered. Prognosis, survival, and the quality of life. Survival is high and with a low percentage of neurologic sequelae for the first 2 degrees of hemorrhage, especially grade 1. There is a good outcome in 95 to 100% of cases. In grade 1 and 65 to 70% in grade 2. In grade 3, significant neurologic sequelae may be present in over 50% of cases. Reaching 70 to 90% in grade 4. Grade 4 hemorrhage is also associated with a mortality rate between 30 and 70%. Post-hemorrhagic hydrocephalus is a common complication of a large hemorrhage. It should be emphasized that a couple having a first child fetus affected with fetal-maternal alloimmune thrombocytopenia have a high risk, more than 80% of a recurrence in the following pregnancies. To avoid recurrence, early monitoring and treatment with intravenous immunoglobulin may succeed in reducing the severity of the recurrence. The take-home message is: once you suspect a fetal cerebral hemorrhage, ensure good search for signs of fetal infection or cerebral tumors. Plan sonographic follow-up and recommend further workup like aforementioned to detect the cause and manage accordingly. A fetus is a human being not only vulnerable to congenital disease but also acquired insults. Hence, pregnancy is a continuous process. It needs regular follow-up. A normal second trimestral ultrasound cannot rule out ongoing fetal abnormalities. The current trend is to do ultrasound at 5 to 7 weeks, at 12 to 14 weeks, at 18 to 22 weeks, at 26 to 28 weeks, and at 32 to 34 weeks. Thank you and kind regards, and see you soon. Assalamu alaikum wa rahmatullahi wa barakatuh. Dr. Amr Farouk.